Hello, this is Dallas Holiday, PGY4 with Midwestern University. Today we're going to be doing a board review lecture. Ultrasound images are becoming more and more common on board exams as well as in real life. So the following presentation is going to cover some key images and pearls to help you pass all your ultrasound questions on your board exam. So as far as lectures, we're going to discuss the pearls and common bedside ultrasound indications. We're going to identify some key images that might be present on these exams. And as always, we really want to pass those exams. So we're going to go by organ system. And first, we're going to start with gallbladder. There are a few gallbladder findings that you need to be familiar with. First, the exclamation point sign is vital for assessing anatomy and determining what structures are being viewed. This view is created by a long view of the gallbladder pointing at the portal vein, which is the point in the exclamation sign. We'll be looking at some images in a moment, don't worry. Next, you must recognize the headlight sign or shadowing created by gallstones if they're present. If you're provided with a clinical picture suggesting cholecystitis and an ultrasound image with gallbladder wall thickened greater than 3 millimeters, gallstones, pericholecystic fluid, then cholecystitis is confirmed. Choledocholithiasis is present when the common bile duct is dilated greater than 6 millimeters and stones are present, or 6 millimeters plus 1 millimeter per decade above the age of 60 years. So for example, if you have an 85-year-old patient, the normal diameter for their common bile duct is going to be 6 plus 2, so 8. So here's an example of the exclamation point sign. You can see that there's a nice long view of the gallbladder, which is pointing right at the portal vein, which makes that exclamation point. And there's the main hepatic fissure connecting the two. So this is a great view just to help orient you so you know what you're looking at. Here we have an example of the headlight sign. You can see very clearly there is a hypoechoic gallstone sitting in the gallbladder and creating a nice shadow behind it, which is our headlight sign. Here we have an example of gallbladder wall thickening. You can see there with the calipers, it's measured at almost 0.6 centimeters or 6 millimeters, which is almost twice the normal size. And then additionally, there's some pericholecystic fluid hanging out behind the gallbladder there. So this would all be consistent with cholecystitis. And in these cases, you're of course going to want to get a general surgery consult. Next, let's talk about FAST exam and trauma. Remember, your FAST exam is going to include 4 key views, which we're going to go over shortly. These are Morrison's pouch, or the hepatorenal flexure, the splenorenal flexure, subxiphoid cardiac view, and the suprapubic view, which is the most sensitive view for detecting free fluid on your FAST exam. And increasingly more common, there is the EFAST, or extended FAST exam, which includes bilateral pulmonary assessment. In the setting of trauma, remember any pericardial fluid is pathologic and will require a trauma consult or transfer depending on what resources are available to you in your question stem. Whenever penetrating trauma is present, the first view obtained is the cardiac view. Conversely, in blunt trauma, the exam always starts with Morrison's pouch. And there's a little bit of an algorithm for blunt trauma when you are using your FAST exam as far as management and disposition for the patient. So if you have a positive FAST exam and an unstable patient, they need to go to the OR. The only right answer is operative exploration. If you have a negative FAST exam but an unstable patient, you have a large differential diagnosis and you need to do some more testing quickly, but are also likely going to need a trauma surgeon consult. If you have a positive FAST exam plus a stable patient, these people can go to CT with close monitoring because you want to further delineate those injuries. Now, if you have a negative FAST exam and a stable patient, you have a couple of options. Serial abdominal examination is perfectly viable choice. Or if CT is your only answer, then potentially CT scan based on what's found on the rest of the physical exam. Now let's look at some images. So here we have an example of our Morrison's pouch. You have the liver in the superior portion there with the kidney below and a large thick stripe suggesting free fluid, which of course, if you're doing a FAST exam and you have trauma, this is a positive FAST exam. Next, let's look at the splenorenal flexure. You can see the spleen in the superior aspect and the kidney down below. And there is a dark stripe of free fluid between the spleen and the diaphragm, which is again going to suggest a positive FAST exam. So of course, if this patient is unstable, they need to go to the OR. Here's our next view, which is your suprapubic view. You can see there the full gallbladder. And then around that gallbladder, you can see a dark stripe, which is going to be your positive FAST exam in the setting of trauma. Next, you have your pericardial view, and you can see there's a large dark stripe around that part, suggesting free fluid in the pericardium, which is always going to be pathologic in the setting of trauma. And again, this is someone you're going to need to call the trauma surgeon for. Now, when you're looking at the lungs, you're looking for essentially two things. You can find pneumothorax or hemothorax. But diagnosing pneumothorax on ultrasound really requires a real-time moving image. So I think it's pretty unlikely that this is going to come up on the exam. However, you should be able to identify a hemothorax on a static image. So you can see here we have the view essentially of Morrison's pouch, but if you just shift up so you're catching the lung, so you've got the liver, the kidney, and the diaphragm. Now normally behind that diaphragm you should see lung tissue. You shouldn't see dark fluid. And here you can see evidence of dark fluid or effusion, which in the setting of trauma is going to be consistent with hemothorax. All right, moving on from trauma and FAST, let's go ahead and discuss OB/GYN. So when it comes to OB/GYN and questions and ultrasound images on board exam, it's a pretty safe bet that most of the questions are going to be related to ectopic pregnancy and frequently involve management of these patients. It's critical to remember that the discriminatory zone values above which an IUP should be visible on ultrasound are 1,500 to 2,000 for transvaginal ultrasound and 3,000 for transabdominal ultrasound. Any beta quant levels below these cutoffs with an ultrasound that does not identify a definitive intrauterine pregnancy will require a repeat beta quant and ultrasound. It's also important to remember normal fetal heart tones are generally 130 to 170 beats per minute, though there is some variability with age of the fetus. Any questions stem with abdominal pain, syncope, unstable vitals, or vaginal bleeding with a positive pregnancy test and a positive FAST exam is a ruptured ectopic until proven otherwise. Accordingly, OR and OB consult will be the proper management. All right, next let's look at some images. So here is the normal female reproductive anatomy in the sagittal plane. You're going to see a bladder superiorly and then posterior to the bladder, the uterus. In this view, it's going to be a long pear-shaped structure. That bladder can be very useful though for identifying your anatomy and what you're looking at. Next, here's the normal anatomy in the transverse plane. So again, you've got your bladder superiorly, your uterus posteriorly behind it, more of a donut shape in this view. And you may or may not catch an ovary, which are frequently described as chocolate chip cookies, because everything in medicine must be described in relation to food. So here we have abnormal. You can see a slightly enlarged uterus with free fluid. Now, this patient is a ruptured ectopic pregnancy, and if you happen to have this image on the exam and you were given a stem with a positive pregnancy test, then this would be a ruptured ectopic pregnancy. Again, here this is the same patient, but a different view. So you can see the uterus there. You can see the adnexa, and you've got evidence of ectopic pregnancy with yolk sac and fetal pole. Combined with that free fluid everywhere is a ruptured ectopic pregnancy. So this patient needs OB and operative management. I think it's fairly unlikely that this is going to come up on the exam, but just to be familiar with it, this is the snowstorm appearance of a hytidiform mole. The question stem in this instance is likely going to provide a patient with hyperemesis, and potentially they may have an abdominal exam that reveals a uterus enlarged for gestational age. Again, I think it's less likely this is going to pop up, but just so you're familiar in case it does. Next, let's go on and discuss renal ultrasound. Renal ultrasound is going to be most useful to look for hydronephrosis in patients with a possible kidney stone or urinary retention. When viewing the kidney on ultrasound, the cortex will appear as gray, surrounding the white renal pelvic fat and calyces. As usual, fluid will appear black. Hydronephrosis will appear as black puddles in the white renal calyces. Remember, an abdominal aortic aneurysm can cause hydronephrosis, particularly on the left. So if hydronephrosis is found on ultrasound, quickly scan the abdominal aorta to ensure that there is no aneurysm present. So this is your normal renal anatomy on ultrasound. As demonstrated here, you can see the cortex and the medulla, which appear gray, surrounding those whiter renal fat and calyces. You should not see a significant amount of black regions within the renal pelvis there. This is a slide just demonstrating hydronephrosis grading. This is going to be mostly a judgment call, and it's unlikely on exam that they're going to give you a borderline case, but it's important to be familiar with the differences between mild and severe. As you can see there, severe is going to start resulting in some cortical thinning, as well as a much larger ureter. So here's an image of hydronephrosis. You can see those dilated calyces within the renal pelvis. In case you can't find those black puddles, there they are. There are 3 more behind those. Here's another example of more severe hydronephrosis. You can see those puddles have coalesced. And additionally, you can see that there is some evidence of thinning of the cortex, which is consistent with severe hydronephrosis. Finally, let's briefly discuss abdominal aortic aneurysm because there's not a lot to cover here. Any abdominal aorta over 3 centimeters qualifies as aneurysmal, although those less than 5.5 centimeters simply require close monitoring. Those greater than 5.5 centimeters will require an elective repair. Additionally, although an aneurysm may be less than 5.5 centimeters, if it is symptomatic, that is also potentially a reason for repair. A patient with unstable vitals and symptoms consistent with ruptured AAA and AAA on ultrasound require emergent surgical consult. Remember, CT scan is never the right answer for an unstable patient in real life and on the exam. So it's important when you're evaluating these images of the abdominal aorta that you measure wall to wall and you don't mistakenly underestimate the size of the aorta because there's a large thrombus present. As this image demonstrates by that first white arrow, if you simply measure the black area, this would generate a false negative. When the aorta is measured properly, wall to wall, you get a true positive of 4.46 centimeters. And you can see there's that large thrombus, and this is going to be a fairly common finding. Here's another example of an abdominal aortic aneurysm, again with a large thrombus present. You can see here, large there, and this is a longitudinal view, which you may see, and again, large there. And this would be quite concerning. Next, let's go through some questions to kind of put all this together. A 36-year-old male with a history of kidney stones presents with 1 day of hematuria, right flank pain, nausea, and vomiting. He denies any dysuria, fever, chills, or abdominal pain. His urinalysis reveals many red blood cells, but is otherwise negative. Renal ultrasound is obtained as shown. His symptoms are controlled in the emergency department with ketorolac and ondansetron. What is the most appropriate management of this patient? So here we have an image of hydronephrosis. You have those dilated black region in the calyces there. So essentially, we have a patient with a history of renal stones presenting with evidence of urolithiasis and hydronephrosis, which is consistent with this diagnosis. His UA is consistent with simple urolithiasis without any evidence of infection. Choice A would be appropriate if the patient had evidence of infection on UA or if he had potentially a single kidney. However, since we have no evidence of infection, we have a history of urinary stones, emergent urology consult is not necessary. Again, admission for IV antibiotics is unnecessary as the patient does not have any evidence of infection on his UA, and he doesn't really need an emergent urology consult as we already discussed. Discharge with pain medication and urology follow-up is certainly reasonable. Now, we could obtain an emergent CT scan of the abdomen and pelvis, which is potentially appealing. However, if you look at the ACEP meaningful use guidelines in patients with a history of kidney stones less than age 50 with symptoms consistent with this diagnosis do not require CT imaging, so that's out. Hence, choice C, discharge with urology follow-up and pain medication is going to be the most appropriate answer in this patient. Next, we have a 23-year-old male presenting to the emergency department after he was involved in a single vehicle motorcycle accident. On arrival, he's complaining of diffuse abdominal pain. His vital signs are slightly hypotensive with a blood pressure of 83/41, a heart rate of 122. Primary survey is intact. Fast exam is as shown. The patient receives 2 liters of normal saline with minimal change in his vital signs. What is the next appropriate step in the management of this patient? So here we have a nice view of Morson's pouch with our liver and our kidney. And in between them, you can see a stripe of black fluid, which is consistent with a positive FAST exam. So essentially, this question stem gives us a patient with trauma to the abdomen, unstable vital signs, and a positive FAST. Choice A, or serial abdominal exams, would be inappropriate for this patient with unstable vital signs. The patient already has a positive FAST exam and a traumatic mechanism, so a DPL would be redundant and not give us any new information in this scenario. As with our previous choices, CT scan of the abdomen is never the correct answer in an unstable patient, but particularly in a patient with a positive FAST exam. This leaves us choice B, which is the correct answer in a patient with trauma and a positive FAST exam and unstable vital signs. This patient needs to go to the OR and they need surgical exploration. Next, we have a 24-year-old female presenting to the ED complaining of vaginal spotting for the last 2 days. Urine pregnancy test completed in triage is positive. Her vital signs are a heart rate of 92 beats per minute, blood pressure of 110/81, and she's afebrile. Pelvic exam is unremarkable. Her quantitative beta HCG is 5,294. Bedside ultrasound reveals the following image. What is the most appropriate management for this patient? So here we have our image, which is a little difficult to delineate, but you can see there a uterus, which is enlarged with no obvious intrauterine pregnancy. And then we've got a significant amount of free fluid surrounding that uterus. So essentially we have a positive pregnancy test with a positive FAST exam, fluid in the pelvis. This is a ruptured ectopic until proven otherwise. However, as we can see with our vital signs, our patient is stable. So our choice A, discharge home with OB follow-up. This is really inappropriate because we know that we have a patient with a likely ruptured ectopic pregnancy, and those patients shouldn't be going home. Methotrexate is an option for a smaller, unruptured ectopic pregnancy, but you're never going to be doing this by yourself. You're always going to have OB as a consult if you're prescribing a patient methotrexate. Repeat quantitative beta HCG and ultrasound in 48 hours is not appropriate because this patient doesn't have a quantitative beta HCG below the discriminatory zone. And we know that there's free fluid, so this is a ruptured ectopic. Emergent OB consult sounds great. Ruptured ectopic equals emergent OB consult and OR. Finally, we have a patient who is a 62-year-old male with a past medical history of hypertension presenting to the emergency department complaining of back pain. His wife states that the patient began complaining of sharp pain in his back and then momentarily passed out. On arrival, the patient is diaphoretic and agitated. His vital signs are a respiratory rate of 34, a heart rate of 128, and a blood pressure of 85/50. Bedside ultrasound is as pictured. What is the most appropriate management for this patient? So here we have an image of our abdomen. You can see there we have a very large abdominal aortic aneurysm with thrombus formation. So essentially this question is giving us an unstable patient with symptoms of a AAA with his back pain and his syncope and evidence of likely rupture with his unstable vitals. So CT scan of the abdomen and pelvis. As I stated earlier, this is never the correct choice in an unstable patient. MRI of the abdomen and pelvis is absolutely not the right choice because MRI is a dark, scary place where patients go to die. Emergent repair in the OR seems like a viable option. And admit for serial abdominal examinations is really not appropriate in a patient who's unstable. So our choice here is going to be emergent repair in the OR and consult your vascular surgeon. That is all. As always, if you have any questions, you can always find me on Twitter at Dallas Holiday and dallasholiday@gmail.com. Here are some references if you want to do a little bit more research or studying on your own. And good luck on that board exam.